Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. My name is Dr. Tariq Iqbal. I am a consultant rheumatologist at the Rheumatic and MSK Diseases Center in Afridi Medical Complex, Peshawar. As rheumatology is an underserviced specialty in Pakistan and specifically Peshawar, my goal is to spread information about rheumatic diseases to as many people as possible. Today we are talking about inflammatory arthritis. There are many types of inflammatory arthritis. In fact, 200 types of arthritis have been described. The most common among them are rheumatoid arthritis, psoriatic arthritis, IBD or inflammatory bowel disease related arthritis, reactive arthritis, ankylosing spondylitis, and gout. Osteoarthritis, which is primarily a non-inflammatory arthritis, also has been reported to have low-grade inflammation, which is called inflammatory osteoarthritis affecting hands. Today we'll focus on rheumatoid arthritis. Rheumatoid arthritis is the most common inflammatory arthritis. The exact prevalence in Pakistan is not known, but earlier studies from 2011 have reported a prevalence of 0.5%, which compared to the Europe and North America, where it stands at 1%, is low. This could be primarily due to a shortage of rheumatologists and as a result, underdiagnosis of rheumatoid arthritis. Rheumatoid arthritis has a bimodal peak, which means that primarily it affects adults around the age of 60, but younger patients in their 30s and 40s can also be affected. The female to male ratio is more in favor of females being affected more than the males. Rheumatoid arthritis primarily is being reported to be linked to smoking and genetic predisposition. There are currently millions suffering from rheumatoid arthritis around the globe. Rheumatoid arthritis usually presents as symmetrical inflammatory polyarthritis, primarily affecting the hands and the wrist joints. Larger joints such as shoulders, elbows, knees, hip, and ankle joints can also be affected. As it is a chronic systemic inflammatory disease, the disease is not just limited to the joints, and it can affect other organs such as heart, lungs, eyes, nerves, kidneys, and even skin, where vasculitis has been reported as a result of rheumatoid arthritis affecting the small vessels. In lungs, pleuritis, pleural effusion, interstitial lung disease has been reported. In the heart, pericarditis. Coronary artery disease has been reported more frequently, just like other systemic inflammatory diseases in rheumatoid arthritis, and it is again due to chronic inflammation and the effect of medications such as prednisolone and steroids being used in these patients, resulting in atherosclerotic heart disease. In eyes, episcleritis, scleritis, and even in advanced cases, scleromalacia perforans has been reported, and this is usually in patients who have been untreated, which can result in vision loss. Felty syndrome, which is associated with leukopenia and splenomegaly, was more common in the past, but now with earlier diagnosis of rheumatoid arthritis has become a rare entity. Again, Felty syndrome responds to DMARD therapies such as methotrexate. Early diagnosis and prompt treatment is the key, as it can result in prevention of crippling and disabling disease and deformities. Now, this can only be possible with a rheumatologist who is properly trained and educated in managing these diseases. In terms of differential diagnosis, it is important to differentiate rheumatoid arthritis from one of the commoner arthritis, which is osteoarthritis. Osteoarthritis affects the joints in which there is thinning of the cartilage, with ultimately joint space narrowing, sclerosis, and extra bone formation, which are called osteophytes, that ultimately results in crippling of the joint. This happens over a period of many years, and patients usually report pain and stiffness. On the other hand, rheumatoid arthritis is a more progressive and aggressive process. Here, the inflammation actually starts in the capsule of the joint, which is called synovium. This results in synovitis, and as the inflammation progresses and treatment is not provided, then it involves the cartilage with erosions that will ultimately result in crippling and joint deformity. After diagnosis of rheumatoid arthritis, it is important to regularly measure the disease activity, and this is a very important point which the patient need to understand. There are currently many validated tools of measuring the disease activity in rheumatoid arthritis. The most commonly used are RAPID-3, which is routine assessment of patient index data 3, CDI, which is clinical disease activity index, and simplified disease activity index. Now, clinical disease activity index and simplified disease activity index incorporates the swollen joint count, the tender joint count, patient global assessment of disease activity, and the physician global assessment of disease activity. In SDI, additionally, CRP is also included. These assessments can be done within seconds to a minute when the patient is in the rheumatology office. RAPID-3 includes the core dataset measures of function, pain, and patient global estimates of the joint status. Each of the 3 individual measures are reported on a score of 0 to 10 with a total score of 30. In RAPID-3, the score of more than 12 would mean a high disease activity, 6.1 to 12 would mean moderate disease activity, 3.1 to 6 would mean low disease activity, and when the score is less than 3, that would mean that the disease is in remission, and in fact there is no active clinical or joint disease activity. Now, these disease activity measures are usually administered by rheumatologists who are trained to use them properly to measure the progress of this disease, and therefore the important thing is to use these disease activity measures on a regularly basis, and to use the same disease activity measure in the patient longitudinally over a period of time so as to gauge the disease activity properly. There are now medications available for rheumatoid arthritis. If rheumatoid arthritis is diagnosed early on time, the patient can have a normal lifespan. On the other hand, if the patient diagnosis is missed and they don't get treatment, then their lifespan, as studies have shown, can be reduced by 5 years. Rheumatoid arthritis treatment is divided into pharmacological and non-pharmacological treatments. The non-pharmacological treatments usually include joint rest, splinting of the joint, heat to the painful joints, and exercises accordingly. And physiotherapists have a role to play here, and rheumatologists usually rely on their collaboration in administering the non-pharmacological treatments. The pharmacological treatments are divided into symptomatic treatments and disease-modifying anti-rheumatic drugs, or DMARDs. The symptomatic treatments include the NSAIDs, or non-steroidal anti-inflammatory drugs, and steroids. These symptomatic treatments usually control the symptoms, but they do not alter the disease course. Steroids do have a small DMARD effect, but primarily they are used as short-term as bridging therapy when DMARDs are started or during flare-ups. Long-term use of steroids is discouraged and should be avoided because of the associated side effects such as osteoporosis, avascular necrosis, diabetes, obesity, atherosclerotic heart disease, hypertension, peptic ulcer disease, skin thinning, and glaucoma. Disease-modifying anti-rheumatic drugs, on the other hand, are medications that would modify the disease course and would slow and even stop the progression of rheumatoid arthritis. Now, these include conventional DMARDs and biologics. The conventional DMARDs are medications which are given orally, and they include methotrexate, leflunomide, hydroxychloroquine, and sulfasalazine. Methotrexate is the backbone of rheumatoid arthritis treatment and has been around for more than 50 years. It is primarily used for treatment of cancers, but in rheumatology, in small doses, it has been shown to control and help in the management of rheumatoid arthritis. As these medications have side effects, regular monitoring of the patients is required, and hence rheumatologist care is very mandatory and important. Biologics, on the other hand, are also disease-modifying anti-rheumatic drugs. These are monoclonal antibodies which usually expedite recovery and even remission in rheumatoid arthritis. Biologics work fast, and usually patients would see the effect within 2 weeks. The commonly used biologics are anti-TNFs or anti-tumor necrosis factor antibodies, which include adalimumab, etanercept, golimumab, infliximab, and certolizumab. Anti-IL-6, which are tocilizumab, and now serelumab is also available, rituximab, Orenzia or abatacept, and synthetic DMARDs. Synthetic DMARDs are JAK inhibitors, in which we have tofacitinib, and now baricitinib is also available. Biologics have revolutionized the treatment of rheumatoid arthritis over the last 2 decades. Now we can get remission or low disease activity quickly with these medications that had not been possible previously with conventional DMARDs. These medications are expensive, and unfortunately, all of them are currently not available in Pakistan. As biologics have immunosuppressant effects, they do have side effects. The main side effects are opportunistic infections, TB reactivation, heart failure, exacerbation, which can happen due to suppression of the tumor necrosis factor activity, psychosis, and worsening of multiple sclerosis. Malignancies such as non-small cell lung cancer and solid organ malignancies have been reported in patients using biologics, but the ratio is not significant compared to the general population. What it means is that the incidence or prevalence of malignancies in general population is the same as in patients who are suffering with rheumatoid arthritis. Hence, these biologics can be safely used in patients suffering with rheumatoid arthritis. Of course, screening of the patients should happen for these conditions accordingly and before starting biologics. In summary, rheumatoid arthritis is a treatable disease. If diagnosed early, patient education is the key, as compliance and proper management and of the activity of the disease is required, and that can be undertaken by a rheumatologist. On the same front, education of and awareness of our physician colleagues, especially orthopedic specialists who also deal with joint and bone diseases, is very important, as disease management is a multidisciplinary teamwork, and this would not be possible without the involvement of orthopedic specialists and other physicians. I hope this presentation will help you understand some of the aspects of this chronic disabling disease, which if left untreated would result in crippling and lifelong morbidity and even mortality for rheumatoid arthritis patient. In the end, I look forward to your cooperation in helping us manage these chronic autoimmune rheumatic diseases and illnesses in Peshawar. Thank you for your time.